Good morning, everyone. Thank you for joining us to this week's Virtual Journal Club. I'm JP Brito. I'm one of the endocrinologists at Mayo Clinic and co-host of these virtual sessions. This morning, we are honored to have three wonderful speakers, two presenters, and one expert discussant. And at this time, I will introduce all of them, so they will start presentations right after. Our first presenter is Dr. Anouk van der Horst-Schrivers. Dr. Horst-Schrivers studied in the medicine University of Maastricht in Netherlands. She specialized in internal medicine at University of Medical Center in Groningen. In 2008, she obtained her PhD in prognosis, follow-up, and quality of life of patients with neuroendocrine tumors. Following her PhD, she specialized in endocrinology. She was a consultant in endocrinology and became the chair of the residency training program. She continued her research activities, especially in endocrine malignancies such as thyroid cancer and endocrine familial tumor syndromes. In 2009, she moved to the southern part of Netherlands, where she's currently working at the University of Sutherland Medical Center. Our second presenter is Dr. Bernadette Dekker. She recently received her PhD degree in the University of Groningen in the Netherlands, investigating gaps in the differentiated thyroid carcinoma guidelines. Her research focused on thyroglobulin antibodies, the low-iodine diet, and the long-term effects of pediatric differentiated thyroid cancer. She was also involved in the development of the new national recommendations for the treatment of pediatric differentiated thyroid cancer in the Netherlands. At this moment, she works in the Department of Internal Medicine of Martini Hospital in Groningen. Our expert discussant for today is Dr. Hennessey. Dr. Hennessey is the director of the clinical endocrinology at Beth Israel and associate professor of medicine at the Harvard Medical School. He graduated from the medical faculty at Karl Francis University in Graz, Austria, and he completed a medical residency at the New Britain Hospital in Connecticut. He served in the U.S. Air Force as an internist/flight surgeon and later subspecialty training in endocrinology and metabolism at the Walter Reed Army Medical Center in Washington, D.C., where he conducted research in thyroxine bioequivalence. Dr. Hennessey served as the chief of endocrinology at U.S. Air Force Medical Center in Wright-Patterson in Ohio, and later joined the faculty in the Wright State University School of Medicine as the director of clinical clerkship, maintaining a clinical teaching practice on Wright State and thyroidology at Wright-Patterson Medical Center. Upon arrival at Brown Medical School in Providence, he transferred to the Air National Guard as a flight surgeon and finally as Rhode Island State Surgeon, retiring after 20 years in the U.S. Air Force career in 2006. Dr. Hennessey's career has focused on the clinical education of medical students, residents, physicians in internal medicine, and fellows in endocrinology and metabolism. In his capacity, he has conducted lectures, presented clinical care, and carried out original and sponsored clinical research with his trainees. Currently, he's pursuing his clinical interest in thyroid disease and osteoporosis with both expanding clinical programs. Today, we're going to be talking about low-iodine diet before the treatment for radioactive iodine. And again, thank you very much to our three wonderful speakers.
So, first of all, we would like to thank the organization for inviting us and the kind introduction. And we are really, really honored to present our work here on the low-iodine diet. And we have no conflicts of interest. And so, since no research can be performed by one single person, we will present this together. Bernadette will discuss our study. And I would like to start with a short introduction, but also explain why we wanted to perform this study. Just to show you some beautiful pictures from the Netherlands, we started the low iodine study with students and patients from Groningen in the northern part of the Netherlands, as you can see on your left. And when I moved to the southern part of the Netherlands, patients from the Medical Center of Maastricht were also included. And on your right are some pictures from the city of Maastricht and its surrounding. And this is daily practice in the Netherlands, because this is our breakfast. It's a sandwich with chocolate sprinkles. It's really nice. You might ask, what's the link between the sandwich and the low iodine diet? During the low iodine diet, which patients have to follow, this sandwich is an absolute no-go. Because Since 1928, there's a law in our country that states that bread should contain highly iodized salt to ensure the iodine intake of the Dutch population. And the baker's salt contains 60 milligrams iodine per kilogram of table salt. And when you consume 4 to 6 slices of bread, which is very common, your iodine intake is about 100 to 150 micrograms. So we always advise to make your own bread when following the low iodine diet. However, we're not going to talk about preparing bread, but we will talk about preparing patients for radioactive iodine treatment before with differentiated thyroid cancer. First of all, as we all know, TSH stimulation is necessary to increase the uptake of radioactive iodine, and this can be achieved by thyroid hormone withdrawal or the administration of recombinant human TSH. All patients have to follow a diet with usually less than 50 micrograms iodine per day for 1 to 2 weeks. This is the low iodine diet. This diet depletes the body's iodine storage, so the radioactive iodine does not have to compete with the dietary iodine. And in addition, it is suggested that it also increases the upregulation of the sodium iodide symporter, and at least this was demonstrated in animal models. So in the end, this low iodine diet leads to an increase of the uptake of radioactive iodine, thus increasing the effectivity of the therapy. And the endpoint commonly used in studies, this diet increases the chances of ablation success. And that's also what we tell our patients. There's solid evidence that low iodine diet with an intake of less than 50 micrograms increases ablation success. Actually, no, there isn't. And I could discuss this for several hours and hope that Dr. Hennessey will come back to this question, because there are no prospective trials comparing a low iodine diet with a normal diet with the outcome ablation success. There are some retrospective studies, often with a historical cohort, and some of these studies are in favor of the diet and some are not. And I personally feel it's a real pity that we didn't perform an RCT on this subject. And if you want to read further, there are 3 low iodine diet. And what about the evidence on the duration of this diet? Also, no prospective studies with the endpoint ablation success, comparing 1 week to 2 weeks or 1 week to 3 weeks. But there are studies with the surrogate endpoint for the body's iodine pool, namely the urinary iodine secretion. And more recent studies show that even in iodine-rich countries, that a duration of 1 week should be sufficient to decrease your urinary iodine excretion. Here the problem is that there is no uniform definition for a successful depletion. As you can see, there are several definitions being used based on the urinary iodine excretion. Some use the iodine creatinine ratio below 66.2. Some say it's effectively decreased below 100 micrograms per gram creatinine. And some use the iodine excretion itself, less than 50 micrograms per liter is okay. And some say less than 50 micrograms per 24 hours. And discussions about that for our study, as Bernadette will mention. And all this somewhat low iodine is, you can see it's in the different guidelines. The American Thyroid Association and the British Thyroid Association recommend an iodine restriction of less than 50 micrograms a day for 1 to 2 weeks. The European Thyroid Association on your right advised 3 weeks until very recently, when a task force changed that completely. As you can see, now any iodine containing drug should be avoided, but it's up to the physician, him or herself, to prescribe this low iodine diet, yes or no. And the Dutch guidelines recommend 1 week, but even in a small country like the Netherlands, we did a survey, and we found out that although we have this guideline, there are some centers who say 4 days, some 1 week, some 2 weeks. So even in a small country, centers do not follow the same advice. And in the Netherlands, we have a saying, it's baat het niet, schaadt het niet, which means something what it might work. It's based on the theory, it really might work, and it doesn't harm patients, but just let's just do it. But in addition, it's not expensive for healthcare at all. And this is what we tell our patient. If your thyroid isn't sufficiently deprived of iodine before the procedure involving radioactive iodine, it could adversely affect the effectiveness of your treatment. So you might have to do the whole thing over again, which could delay your treatment. And that can be really stressful. The low iodine diet can be a real challenge and can also be a source of anxiety. And sometimes patients confuse it with a low salt diet, and especially with thyroid hormone withdrawal, this can lead to hyponatremia, and I'm sure you've all met those patients. We also have our own experience. Some time ago, 10 medical students needed a research project, and we challenged ourselves to follow this low iodine diet for only 4 days, so not 2 weeks, but 4 days. And on day 4, we collected 24 urine. So I have a very busy life with my work. I have a husband, 2 children, and cooking is not my hobby. So I don't have a lot of time, and I didn't have a lot of time to study this diet. So I did the following. On Sunday, I made 4 liters of tomato soup, and I baked my own bread without the iodized salt. And this is my menu. Day 1, I ate bread, butter, and tomato soup. Day 2, bread, butter, tomato soup. And you can see on day 3 and day 4, I ate the bread, butter, and tomato soup. And that's not all, because my whole family was on this diet, and my husband was even forced to participate in this pilot study. And at the end, 50% of the participants, so the students and my colleagues, achieved the target level of less than 50 micrograms per liter. I didn't, and I learned 3 important lessons. I really have to increase my water intake, and I have to drink, I should stay off of the cappuccinos, because I drank a lot of cappuccinos and they contain a lot of milk with iodine. So that was my failure. But most of all, this diet is really, really, really difficult. So we wanted to make some improvements for the patients. And first of all, 5 of the medical students who participated in the first studies, together with the patient organization of the Netherlands, they made a website with low iodine recipes. And that was really a lot of fun. And second of all, based on 2 studies, by Kang and by Kim. They both studied the daily iodine excretion in patients. And in both studies, you can see in this graph on the y-axis, you see the urine iodine concentration. And on the x-axis, the days after the start of the low iodine. And this is in an iodine-rich country. But you can see this excretion dramatically decreases the first days and thereafter stays constant. So we wanted to see if 4 days would be enough for our patients. So to summarize, the low iodine diet theoretically increases ablation success, but the evidence is rather low. Guidelines differ regarding duration. The clinical practice between the different hospitals differ. And baat het niet, schaadt het niet. I'm not sure whether this is true, because the low iodine diet can be very stressful, and we have experienced that for ourselves, and very difficult. And based on the daily urinary iodine excretion, 4 days might be sufficient to deplete the iodine body storage. And you might wonder, is this reduction of 3 days, because it's only 3 days, worthwhile to start a study? And we thought it was. And with this, I would like to give the word to my colleague, Bernadette.
Thank you, Anouk. Good morning. First of all, thank you again for the invitation to speak about our research. And I want to discuss our article with you. Next slide. Our first aim was to investigate if a low iodine diet of 4 days also leads to an adequate iodine depletion in DTC patients living in an area sufficient iodine intake, because that's what the Netherlands is. And we also evaluated the nutritional status of our DTC patients during the diet and asked them to share their individual perceptions with us regarding this diet. Next slide. We performed a prospective multi-center study in 2 university centers in the Netherlands, Groningen and Maastricht, between May 2018 and March 2021. And based on the result of the study of Kim, our analysis showed us that we have to include 65 patients. Patients could not join our study if they used iodine-containing drugs, had a diagnostic scan with iodinated contrast in the last 3 months, or were not able to understand Dutch. According to the hospital protocol, patients had to follow a low iodine diet for 7 days with an iodine intake of less than 50 microgram per day. Patients received written instructions, a sample menu, and a website mentioned before with the low iodine recipes. They could also call a dietitian if they had questions for her. To answer our first aim, patients had to collect their urine for 24 hours on day 4 and 7 of the diet, and we compared the 24-hour urine excretion of these 2 days. Besides, we calculated the percentage of patients who fulfilled different definitions of an adequate low iodine preparation. As mentioned before, we struggled with the ultimate definition of an adequate preparation because different definitions are used in literature. However, we think a 24-hour iodine excretion below 50 micrograms per day is the strictest reference standard, since most iodine is eliminated by urine. To answer our second aim, we asked patients to keep a food diary 3 days before and 4 days during the diet. The 3 days before the diet would give us some insights of their normal diet choices. Our dietitians calculated the intake of different macro and micronutrients as a percentage of the dietary reference intake. To get more insight in the individual perceptions of the low iodine diet, we asked patients to answer our self-made questionnaire. For example, we ask about their compliance to the diet and their experience of composing a day menu. 124 DTC patients were eligible for inclusion. In total, 59 patients did not want to participate to the study. And most people declined at the end of our inclusion period because they were overwhelmed by their disease in combination with the start of the COVID-19 pandemic. The 65 included patients had a mean age of 54 years, and 74% of the patients received their first radioactive iodine treatment, so also their first time of doing the diet. Only 3 patients were prepared with recombinant TSH. The median 24-hour urine excretion, as you can see on the slide, on day 4 of the diet was 36.1 microgram, which was not significantly different from day 7. We saw that the median individual degrees between day 4 and 7 was only 4.7%. As we see in the figure, 1 patient did not understand the instructions of the diet very well, and 2 out of 3 patients who were prepared with the recombinant TSH had an urine iodine excretion below 50. Our secondary outcome, using the strict reference standard, 72.1% of the patients were already adequately prepared on day 4. After another 3 days, 82% fulfilled this definition. On day 4, 80% of the patients had an excretion below 50 micrograms per gram creatinine, and almost everyone had a excretion below 100 microgram per gram creatinine on day 4. The data on this slide were not reported in our article and were not powered, but we were curious about the ablation success of our patients. Ablation success was defined in low-risk patients as a negative ultrasound and a stimulated thyroglobulin below 1. And high-risk patients also has to have a negative iodine scan. Ablation was measured after 6 months. So for this evaluation, we could not include the patients who followed this diet for the second time or were lost to follow-up because we didn't have the data. And focusing on the urine iodine excretion, so that's the table on the left side of the slide, we found no significant differences in ablation success between the two groups, as you can see, both 75%. Focusing on ablation success, so yes or no, on the right side of the slide, urine iodine excretion was not a significant difference between the patients with or without a successful ablation. Compared to the regular diet, DTC patients showed a significantly lower intake of calories, protein, calcium, water, and of course iodine during the diet. We were wondering if patients had a lower iodine intake at the beginning of the diet, because in general, most people start motivated with every diet. But we found no difference between the iodine intake during the first days and on day 6 of the diet. And our last aim, the perceptions, 91% of the patients reported compliance to the diet for the recommended 7 days. Patients with a higher iodine excretion did not report other individual perceptions. We also found no differences in characteristics like age or gender between the patients with a low and a high iodine excretion. This was not what we expected. Most people experience no barriers against the diet. However, on an individual level, we noticed difficulties in composing a daily menu. I remember, for example, a patient who called me when she was in the supermarket and asked me about the iodine content of some products. Another patient called me around dinner time because she made a delicious pasta sauce, but she asked herself last minute, how many iodine is in this sauce? And she asked me if she can eat her meal. Besides, some patients are also experiencing stress of contributing to treatment failure. The diet is the only thing of their treatment they can control, and they don't want to make mistakes. So in conclusion, a low iodine diet of 4 days is sufficient preparation for radioactive iodine treatment. The effect of an extension of 3 days is neglectable. In our population, almost 75% of the patients achieved an urine iodine excretion below 50 micrograms per day on day 4 of the diet. At this moment, our guideline is being revised and we will advise a diet of 4 days. It's hard for patients to achieve a balanced diet during the low iodine diet. The intake of imported nutrition is extremely decreased. Finally, we need to have attention for those patients who experience stress of contributing to treatment failure. The strengths of our study were the prospective design and the collection of 24-hour urine. The results can be used in countries with sufficient iodine intake. Unfortunately, we could not give an advice for iodine-rich areas and patients who are prepared with ARTSH. Another limit of our study are the self-reported nutrition diaries, because we know they are vulnerable for underestimation. However, we compared two periods, before and during the LID, of 1 person. So for the additional questions, next slide, please. It would be very interesting to investigate if a diet of 4 days is also suitable for patients prepared with recombinant TSH. Besides, it would be also interesting to investigate if it's suitable for patients living in iodine-rich areas, for example, and more in Asia. But maybe the most important question, what is the additional effect of the low iodine diet on the outcome of radioactive iodine therapy? We would like to thank our co-authors for their help and their support. And we would like to thank you for your attention.
Thank you very much. So now we go with you, Dr. Hennessey.
Okay, well, ladies, thank you very much. That was a fantastic presentation. And if my presentation has overlap, I'll try to acknowledge your superior handle on this data. And I'd like to congratulate both of you, as well as all your co-authors, on a very well-designed and executed study. Thank you for doing that. It was very, very good. I'm afraid to say that what I'm going to say next might be a good illustration of how the literature on this topic really is a collection of papers from the Journal of Irreproducible Results because of study design differences and outcomes. So every study I'm going to talk about more or less stands alone, and it's very difficult to synthesize this. And I think the plans to do this prospectively is a good idea. So let me go to share screen if I understand the process correctly. And I will try to get that done for you. Okay, so as is our need, we disclose before and after, and I have none to share here because I don't work for a low iodine diet company. So the ladies pointed out to me previously that I'm somehow considered an expert in this area because I've been able to trick residents and fellows into writing review papers with me. And what you're going to see next are a few excerpts from one of the reviews that we put together that was published in 2016. I must say Josephine Lee did a spectacular job on this particular paper. But she reminds us in this review that the U.S. Institute of Medicine recommends an RDA of about 150 micrograms a day. And so we have similar recommendations than what the reality in the Netherlands are. Now remember that sources of dietary iodine for your patients include iodized salt, but certainly not exclusively there. And in the old days when bread could not be kept fresh with plastic wrappers, there were preservatives that were full of iodine that were put into bread in this country. And I think that Elizabeth Pierce and her colleagues have demonstrated that if you go into a few markets here in Boston and buy some bread and then analyze the iodine content, you never know what you're going to get, and it doesn't even match what's on the label. So the use of iodized preservatives in bread in this country is quite variable. But other sources are dairy foods, seafoods, and grains. Now, if you're a seaweed fan, you may be underdosing yourself if you've got a seaweed that's only got 16 micrograms per gram, or you may be grossly overdosing yourself if you wind up with some seaweed that tops out at 8,165 micrograms per gram. So seaweed is very variable. And I usually tell patients not to rely on seaweed for their iodine intake, and certainly not to overdo seaweed because it could actually make them quite overloaded with iodine. One concept here that I had forgotten over and over again was that levothyroxine has a substantial amount of iodine in it, about 63% by weight. So a 200 microgram tablet, for example, has 126 micrograms of iodine, which obviously would be at least twice what the low iodine diet itself for the whole day should contain. So I didn't think about this before we started using recombinant human TSH, because everyone had been withdrawn from thyroid hormone. A source of iodine to keep in mind. So as you heard, urinary iodine concentrations reflect the dietary intake, and they are a measure of total body iodine status. Now, these are definitions that we ran across in some review articles saying that if you're normal and you've got a normally functioning thyroid, then your urinary iodine output would be optimal if it's somewhere between 100 and 200 micrograms a day. But if you're in a country with mild iodine deficiency, we would expect 50 to 99 micrograms a day. Moderate deficiency, lower than that, 20 to 49. And severe iodine deficiency, less than 20. So as you see, with these low iodine diets, we're typically shooting for mild to moderate iodine deficiency rather than severe iodine deficiency. Now, the N. Haynes study in 2005, and I'm sorry I haven't updated this, but this is what was in Josephine's review, demonstrated that the median urinary iodine concentration in the US was about 164 micrograms a day. But 8.8% of the US population were iodine deficient with less than 50 micrograms a day. And about a lower percent were iodine superficient with over 200s, especially found in children, probably because of a lot of dairy food intake, and those of us over 70. Whoops, I shouldn't have said it that way. Women seem to be iodine insufficient more frequently than men, 11.3 versus 6.1%, almost twice as likely. And vegans are at greater risk of iodine deficiency, as the studies of, again, Elizabeth Pierce and Dr. Sun have demonstrated to us. And this is a real favorite of Elizabeth's. Pregnant women have a median urinary iodine concentration of about 125 in 2005. And the FDA actually recommends 250 micrograms a day during pregnancy. And we have a campaign at the American Thyroid Association to make sure that all pregnancy-related multivitamins contain sufficient iodine. Now, this all breaks down worldwide to about 30 countries that are considered to be iodine deficient. So you might think, well, if you're already iodine deficient, how much more impact would a low iodine diet have? Ah, good thought. And about 10 countries where there is actually iodine excess, so beyond adequate and into excessive amounts. And some of the known countries with iodine excess include Japan, Korea, and this is a real guesser for me, Canada. I don't know what they're reading up there. But obviously, as you heard, measurement of iodine depletion, which should be a reflection of low iodine diet compliance, is assessed with a 24-hour urinary iodine concentration, which is the gold standard, versus urinary iodine concentrations controlled for creatinine, which correlates very well and accounts for hydration in the patient. So I wanted to go over a few studies that were both positive and negative and point out, since this is a journal club, where the issues were that might make us scratch our heads and say, well, I'm not going to believe that one. And again, this really sets us up for a review of the literature in the Journal of Irreproducible Results. Now, they all came out in different journals, so let's not get too confused. So this is from UCLA, not UCLA, from Los Angeles. I can't remember exactly where it was conducted, but there were 44 patients, all of whom were on thyroid hormone withdrawal, and had a 2-week so-called low iodine diet, which was compared to 50 subjects who were on a so-called regular diet. Now, you'll see in just a second that the regular diet was not regular at all. But this is one of the first studies to say, hey, it doesn't really matter whether you put people on a low iodine diet or not. It makes no difference in successful ablation rates. So those on the low iodine diet were successfully ablated 68% of the time, and those on the regular diet were successfully ablated 62% of the time. Now, let me remind you, all of these patients were prepared with thyroid hormone withdrawal. So that 126 micrograms per 200 microgram levothyroxine tablet were not in their diets. So here's the urinary iodine excretions on the low iodine diet and the so-called regular diets. Now, if people were on the regular diet, they were specifically instructed to avoid intake of salt, multivitamins where iodine was on the label, all seafood, all sushi, and shellfish. So this is sort of a modified low iodine diet, but it's called the regular diet group here. Now, on the left, we see the low iodine diet before instituting the low iodine diet, and the 24-hour urine iodine concentrations ranged here from 175 to greater than 1,000 micrograms per liter. And notice up here that it's about 550 micrograms per liter, which some people might say, whoa, that's on average a lot of iodine in the diet. Now, after the low iodine diet, obviously, when they followed it for 2 weeks, it dropped to about 176, which is a substantial decrease. But the range of urinary iodines that were observed in this group, who were supposedly the compliant iodine dieters, ranged upwards of 450. So some people, even after 2 weeks of apparently a low iodine diet, still had not reduced the amount of iodine in their urine. Now, those who were on the so-called regular diet before avoiding salt, etc., ranged from 250 to 830, and their urinary iodine did drop a bit by avoiding these particular buzz things. And the control group, which were already also recruited and evaluated at the same time, had a range between 50 and 1600. This is California, of course, so there are extremes there of vegans versus those that are seaweed consumers. But the median, well over 400 micrograms a day. So the median in Los Angeles appears to be quite a bit higher than what the NHANES data would lead us to believe it should be expected. Now, when we talk about how much urinary iodine is too much, which when it's talking about outcomes, we're concerned that we're flooding the body with iodine and therefore the radioactive iodine doesn't have a chance to be effective. You're going to see some information that might say, well, 100 micrograms a day or higher is too much. And in the current study that we just reviewed, the comparison was between less than 50 micrograms and over 50 micrograms. And we'll talk about that in just a second. But where's the cutoff? You know, how much iodine is too much? Is it 100? Or maybe it's 250, and you'll see some data on that coming up. But notice that essentially all of these groups had excessive amounts of iodine in their urine. So to conclude that a low iodine diet is of no value might actually be a lead article in the Journal of Irreproducible Results. So that's the Morris study. And I've always, the senior author in this study is a good friend of mine. And so I've actually spoken to him about this and said, I don't know what to do with that data, Glenn. And he has said, well, that's why I'm sticking with male hypogonadism at this point. So in this particular study from Morris, the low iodine diet compliance was questionable. As I said before, the mean urinary iodine concentration was about 174, but look at that range, it was a lot broader. And the regular diet and the control populations demonstrated much higher urinary iodine concentrations than you'd expect. So that may highlight limitations of using historical population controls. And the range of the urinary iodine concentrations included, at least in my opinion, many who would be considered to be iodine contaminated and probably should not proceed with the radioactive iodine treatment. So the other little twist here was in the regular diet, they got higher doses of radioactive iodine. So it wasn't a fair comparison of, let's say, 100 millicuries versus 100 millicuries in both groups. The regular diet people got higher doses of radioactive iodine, which would obviously, at least in my opinion, probably result in higher ablation rates. So another study, and I can't pronounce this name correctly, but Ploijem reported on radioactive iodine ablation rates in 120 differentiated thyroid cancer patients who were selected to have no evidence of any metastases. And they underwent a thyroid hormone withdrawal preparation and a 4-day low iodine diet. Isn't that similar? They reported that their 24-hour urinary iodine concentration was 26.6 micrograms on low iodine diet versus 158.8 in their controls. So that should give you a big enough spread to perhaps be able to pick up a difference in outcomes. And they reported a 65% ablation with the low iodine diet versus 48% ablation in historical controls who did not follow a low iodine diet. But any patient who had a urinary iodine greater than 50 was excluded because they were considered to be non-compliant. So we have shrunk the difference between the two groups together in order to exclude 50 or higher. And this is considered one of the positive studies of low iodine diets actually work. But there's some things that make you question, do I really believe that? Talaguri is another one of these positive studies, but they concluded, even though there was an advantage, it seems, in the ablation rates, that there was no association between the urinary iodine concentration and the outcome. So when they were looking at the scale of urinary iodine concentrations, they couldn't see a real difference. However, none of these subjects were actually being treated with a low iodine diet. So it's probably not reasonable to assume that this is good evidence that low iodine diets work, since no low iodine diets were utilized. And they did not correct the urinary iodine concentrations with creatinine. So the wild card of hydration was not played. Remember that if you drink lots and lots of pure water, you can dilute your urine, and that will effectively diminish the urinary iodine concentration. But all that being said, this is considered to be one of the trials that has a positive impact of low iodine diet on outcomes, even though nobody was on a low iodine diet. Sun et al. Looked at 295 postoperative papillary thyroid cancer patients. Now you're noticing that the N is getting bigger. And they were prepared with thyroid hormone withdrawal and a 2-week low iodine diet. And the ablation rates in this study were lower if the urinary iodine concentration corrected for creatinine was less than 250. So they were one of the first to come up with a cutoff to say, you know what, if your urinary iodine is greater than 250, maybe you shouldn't treat with radioactive iodine because there are poor outcomes when it's that high. Now, the ablation rates were very similar if it was less than 50, 50 to 100, 100 to 250. But if it was greater than 250, then the ablation rates were significantly lower. And this, again, is another positive study of the low iodine diet having a beneficial effect on outcomes with radioactive iodine. You et al. Showed no difference, on the other hand, in 2012 in outcomes in 161 differentiated thyroid cancer patients. And their primary focus was, we're going to give them a very strict versus a less strict low iodine diet. And then they didn't measure urinary iodine output. So I don't really understand how objectively we were supposed to figure out whether they actually followed this very strict or less strict diet. And Lee et al. Showed no difference in outcomes in 195 papillary thyroid cancer patients when the urinary iodine concentration was less than 50 versus those 50 to 100, which is, I believe, similar to the results in the current study, where everybody seems to be fairly well prepared, because no one in this study had a urinary iodine concentration greater than 100 micrograms per liter. So in my opinion, they'd all be considered adequately prepared. So the advantage of less than 50 is not apparent, and I would agree with that. So subsequently, this is a newer study that has been published by Herbert et al. And this is a meta-analysis. Now, this is one of Dr. Brito's favorite tools here, doing meta-analysis. So he's really going to understand the methods a heck of a lot better than I did. But in this systemic review published in 2022, they did a mixed methods review with literature up until February of 2021. And indeed, their analysis does conclude that there's a greater ablation success if the urinary iodine excretion here is less than 50 per gram or liter versus comparison with greater than 250. Again, bringing up the cutoff value with, well, if it's very high, try again with the diet. But if it's less than 50, you're in good shape. And the odds ratio here was 2.3-fold difference, with the evidence, of course, being very low. And here's the forest plot of that, looking at the two studies that were included with enough clear-cut data to be able to make a conclusion. And here's less than 50 versus 200, greater than 250. So it was limited as to how much could actually be compared within the literature, because each study was designed differently and reported differently. But it does look like less than 50 versus greater than 250 probably has a positive effect on the outcome of radioactive iodine. Now, here are the urinary iodine concentrations and the ablation rates in a study of by Zhang et al. From 2021, which came out subsequent to that meta-analysis. And this looked at 181 patients receiving radioactive iodine. They had otherwise normal function, no thyroglobulin antibodies. And anybody with a urinary iodine excretion greater than 1,000 per liter was excluded. They had amongst their patients 113 that were classified as ATA low to intermediate risk. These are the LIRs, and then 68 ATA high risk, which are the HRs. So the overall successful ablation here was found in the whole group to be about 93.8% in the low to intermediate risk patients and about 91.2% in the high risk group, which are quite similar. However, when assessing excellent ATA responses, which occurred in about 60% overall, those with low to intermediate risk had an 86% excellent response versus 29% in the high risk group, which makes sense because higher risk disease probably has more residual. So here's low to intermediate risk differentiated thyroid cancer. And on the left-hand side here, we're going to see the excellent response rates. So if the urinary iodine concentration was less than 100 here, excellent response was found in this group at about 55%, or just, well, yeah, about 55% versus when it was greater than 100. So maybe that's another cut point, 100 versus greater than 100. And over here, the non-excellent response was found when the urinary iodine concentration was greater than 100 and was lower when indeed lower urinary, the response rate was lower when in these non-excellent response patients when about 30% response rate in them. So it does appear that the urinary iodine concentration did reflect a differentiation with who was responding adequately and not. Among the high-risk patients with differentiated thyroid cancer, Zhang et al. Was not able to demonstrate any impact of the low iodine diet. Now, this is a abstract that we presented at the last ATA meeting, asking the same question: do low iodine diets impact on outcomes? And we had 304 patients after total thyroidectomy for differentiated thyroid cancer undergoing their initial radioactive iodine ablation. And they followed a self-administered, similar to the current study from a handout, diet that was designed to deliver less than 50 micrograms per day for 2 weeks prior to scanning and the ablation sequence. And we obtained urinary iodine creatinine ratios with spot urines a few days prior to the radioactive iodine treatment. Now, our primary endpoint was to determine who was and who was not experiencing recurrence or persistent thyroid cancer at 18 months after the radioactive iodine treatment. And here are the defining findings for the presence of recurrence or persistence: either elevated basal thyroglobulins, granted, minimal; stimulated thyroglobulins, which were elevated, granted, minimal. We wanted to be as sensitive as possible; positive neck ultrasounds, or positive whole body scintigraphy. And then we did multiple regression analysis to look at these outcomes. So here's urinary iodine to creatinine ratios in thyroid hormone and recombinant human TSH stimulated patients versus outcomes. On the left are the thyroid hormone withdrawal patients where we can see that the mean urinary iodine to creatinine ratio was lower in those who were disease-free in the blue bars versus those with persistence and recurrence. And we could see that there was a substantial impact of having a lower urinary iodine concentration. On the other hand, notice over here in those stimulated with recombinant human TSH, and there were lots of them, we were unable to detect a clear-cut difference. So in the multivariate analysis of the entire cohort, after we adjusted for everything plus shoe size, there were higher urinary iodine to creatinine ratios associated with an increased likelihood of persistence or recurrence, which, although I'm not a fan of statistical significance, I'll take it. And we thought that the urinary iodine did predict the outcome to some degree. So when we take a look back at our review here, currently there's truly no standardized guidelines beyond 1 to 2 weeks for adequate preparation. And the comparison of 1 versus 2 weeks on low iodine diets as assessed by urinary iodine concentration is illustrated by this 2005 study here after a simple handout in the office, which was self-administered, which I believe is the appropriate way to do this to conserve resources. 70% of patients on low iodine diet for 2 weeks achieved a urinary iodine to creatinine ratio less than 100, whereas only 26% of those on 1 week had the same outcome. And here's your 2 week mean, 63.1 versus the 1 week mean, which is nearly 120. So I'm just going to show off for JT Park, who's an IM-PEDS kind of primary care guy who I tricked into doing a study with me back in Providence. And we looked at 1 versus 2 weeks of low iodine diet and see how that worked out. Now, here are the patient populations. 31 patients undergoing thyroid hormone withdrawal were prescribed a 2-week low iodine diet, less than 50 micrograms a day, simple handout. 23 patients were prepared with recombinant human TSH, and they followed a low iodine diet for 1 week because that's what the package insert for the recombinant human TSH said was done in the pivotal studies. And then we figured out that their urinary iodines were far higher than we were comfortable with. So we changed our protocol to give those prepared with recombinant human TSH 2 weeks of diet prior to scanning. And what I'm going to try to show you here are the urinary iodine and the creatinine outcomes just prior to scanning. There's no outcome data here other than our guess. So here's 2 weeks, no thyroid hormone, so thyroid hormone withdrawal, and making an assessment, are they well prepared? 78% after 2 weeks, well prepared by a less than 50 micrograms per day grouping here. Notice that nobody was adequately prepared, but we did have a smaller group that were inadequately prepared with urinary iodines up to about 250. And then we had our category of poor preparation here, which was greater than 250. So 2 weeks seemed to be fairly successful in getting patients who were off of thyroid hormone into an acceptable range. Now here's, I'm having a hard time reading the top of the slide here, but this is the impact of levothyroxine on urinary iodine outcomes. All of these patients were prepared with 2 weeks of low iodine diet and were prepared with recombinant human TSH. So they remained, some of them remained on thyroid hormone and some of them were thyroid hormone withdrawn. So here's the group with thyroid hormone withdrawal, and they had a median urinary iodine to creatinine ratio of about 25 versus those that were prepared with recombinant human TSH, where the median urinary iodine to creatinine ratio is about 75. So a substantial difference with levothyroxine, and yet still on average less than 100. So here's 1 week versus 2 weeks while on levothyroxine, and we were able to show that After 1 week, our patients were sort of like, oh, maybe I should get on this diet and start following it. So there was further reduction after 2 weeks. We attributed this to patients not paying attention for the first week. So here's ablation successes, again, from the systemic review, looking at strict versus less strict diets, and incumbent in that is 2 weeks versus 1 week. And universally, we see that 2 weeks seems to have a lower urinary iodine concentration. But strict versus less strict doesn't look like there's a big impact. So here's stricter versus less strict low iodine diets, and notice that the forest plot here does not favor one or the other. And this is when we look at the outcomes after radioactive iodine. On the other hand, if you look at the urinary iodine excretion, strict is indeed a little bit more successful in dropping the urinary iodines. On the other hand, here's 1 week versus 2 weeks in the meta-analysis, and notice it does favor the 2 week low iodine diet overall in the literature of irreproducible results. And there's our little study from 2004 sitting on top of the mound there. And when it comes to 2 weeks versus 4 weeks, well, the good news is going beyond 2 weeks doesn't seem to have any further impact. Now, you saw this previously, and I would simply like to point out, and I hope I interpreted the results in the published study correctly, that all of their patients after 4 days had urinary iodines under 200. And so that would be considered probably to be successful if indeed that cutoff of greater than 250 is really the important number. On the other hand, by day 7, essentially all of their patients were less than 75. So if lower is better, well, then maybe 7 days is better, but I'll reserve comment on that. And so if I were to make any comments about low iodine diets, 4 versus 7 days, I would again congratulate the speakers and say that their instructions seem to be minimal, but what's not clear to me is how often do subjects consult the website and consult with the dietitians. And I must say, Bernadette, that you are far more accessible to your patients than I am. Nobody calls me during dinner to ask if their low iodine diet has been disrupted by their child throwing something across the table or whatever that question really was all about. So congratulations, that is really good patient service. But the other thing to point out here is that there was no urinary iodine excretion collected while the patients were on a regular diet. So the actual impact of 4 versus 7 days on reducing the urinary iodine excretion is a little bit less clear because I'm not sure how accurate food diaries are to determine this. But it does appear that 95.4% of the subjects were well prepared with thyroid hormone withdrawal, which, as we demonstrated previously, would have a substantial lowering effect on the urinary iodine excretion. So when it comes to thyroid hormone withdrawal complaints, when I used to do that on a regular basis, my patients would be so distracted and so miserable because they were hypothyroid that I didn't hear a lot of complaints about the low iodine diets. However, now that we're using recombinant human TSH, the complaints predominantly are about the low iodine diet because the patients are still euthyroid. So I actually had many patients with TSHs in the 85 to 100 range who were quite symptomatic and had actually lost weight during the preparation period because the low iodine diet was so bland. And I asked, well, are you happy about the weight loss? Oh, yeah, I'm really happy about the weight loss, but X, Y, and Z would be their complaints. So in this particular study, it seems to me that all the subjects seem to be optimally prepared for the radioactive iodine after 7 days, where nearly all of them were optimally prepared after 4 days. And I would just throw a question out to the authors to ask, are you still going to assess urinary iodine concentrations prior to administering the radioactive iodine after you employ this 4-day diet? But I think there the rate limiting step would be how quickly can you get the urinary iodine turned around so that it might make a clinical difference. So in summary, I would say that low iodine diets generally are designed to deliver less than 50 micrograms of iodine daily. Their primary side effect, as our review points out, is hyponatremia. So in older patients, especially women on thiazide diuretics, be careful when it comes to this, because a lot of patients, especially when prepared with thyroid hormone withdrawal, might have difficulty with that. The literature currently supports 1 to 2 weeks of low iodine diet with a slight favor towards 2 weeks for lower iodine levels. But as we see, I don't know that it really makes that much difference. As long as everybody's less than 100 micrograms per gram of creatinine, for example, they're probably adequately prepared. And the good news is that durations greater than 2 weeks have no additional benefit. Now, intense patient education may improve low iodine diet success rates, not for outcomes, but certainly for lower iodine concentrations, and therefore might require shorter durations. So if you have no dietitians to instruct patients and just working from a handout, such as the current study, this is a very positive finding to help us feel reassured. I think that spot urinary iodine to creatinine ratios are reliable reflections of iodine depletion. So I actually consider postponing the radioactive iodine if the value is greater than 250, usually because the patient has stumbled into an emergency room somewhere and gotten IV contrast that nobody knew about. But sometimes it's just because they didn't understand the diet, nor were they willing to participate. And the impact of any low iodine diet is still a little bit difficult to demonstrate. And it looks like the outcomes might be clearer among those with thyroid hormone withdrawal. And I certainly agree with the authors that we need more work to try to figure out whether with recombinant human TSH preparation, low iodine diets are having much of an impact at all. And we're currently trying to tease out of our data the group that with the highest urinary iodine levels, greater than 200, greater than 250, versus those less than 100, to see if that makes a difference. So thank you very much for the invitation to be here. I hope I didn't talk too long. And again, I have nothing relevant to disclose, but I am very impressed with the study that we were just looking at.
Well, that was a fantastic review, Dr. Hennessey and Dr. Horst-Schrivers and Dr. Dekker. Wonderful study. Congratulations. I think we are left with many interesting questions here. I think you have pretty much summarized what the next steps of the field should be. And we are very curious about how to better treat patients with receiving recombinant TSH, since this probably is becoming the trend in the United States, at least. We're left a little bit with the where should we think about patients with high risk thyroid cancer in regards to the efficacy in that particular group, since in low risk thyroid cancer might be that there is not really a significant signal. As you can see here, unfortunately we ran out of time, but again, to send my congratulations to all of you, and thank you very much for being with us.
I'm sorry.
No, I think the review was wonderful. I appreciate Dr. Hennessey. So you know, we can think about reconvening again, but certainly that review was worth it.
Yeah, I was not trying to dominate the conversation, but
no, it was great.
Somehow 18 slides turned into you know, just too much talk on my part. Sorry.
No. And the audience, thank you very much for being with us, and hopefully you will join us next week as well. Thank you, everybody.